thank you. I want to extend my welcome as well. I was a faculty member here for 32 years. I retired about 5 years ago. You can see how retirement really is working for me. My husband keeps saying, "Are you really retired?" But I pick and choose, so I can come and talk at these kinds of things and not have all of the other bureaucratic responsibilities that a faculty member has. I want to get a sense of how many of you are from shelters that have computerized systems now. Anybody not have computerized systems? So you have a few. Most of what I'm going to say today is going to be really hard to do without some kind of a computerized system. And really would encourage you, if you are in an organization that will listen, to try to get a computerized system. How many of you are entering medical-related data into your systems? Wonderful. That's really great. How many of you are entering actual diagnoses as part of some of that medical data? So somewhat fewer of you. Good. How many of you are pulling out and counting the number of cases, for example, of upper respiratory tract infections in cats? Good. And how many of you, when you pull those, actually are calculating rates? That is, the risk of developing upper respiratory tract infections. Not as many, and very few of you. And that's completely understandable. Just as a little bit of a background, I did found the shelter medicine program here at Cornell and directed it for about 8.5 years. But I am, by training, a veterinary epidemiologist, hence my interest in data. And I came from a preventive medicine background that was using data. What I would really like to do today is encourage you, if you're not already, encourage you to think about how to use your data more extensively to improve population health. I would like also to just show you some examples of things you may or may not already be doing, and demonstrate some of the calculations for those of you who haven't made calculations of rates in particular, and then share some insights into collecting some of that data. I think most, and I hope all, all of our animal shelters have as one of their primary objectives to provide for the best welfare that they possibly can for their animals. And part of providing for that best welfare is to minimize disease. Disease causes suffering, and we are organizations that are devoted to minimizing suffering. We want to shorten stay, keep these animals in our shelters as short as possible, and we want to prevent euthanasia as examples of how the medical program can play into the mission of the shelter. And I believe, and I hope I can convince you, that collecting data and looking at the data and actually examining the data can help you do that better than just not using that data at all. Okay. Data are just another tool. They're not a panacea. It's not, many of you are not potentially using the data to the maximum extent right now. That's okay. Doesn't mean you're not doing a good job. But it's one more tool that if you use it more extensively, I think can improve the health of your animals even more than you have right now, or certainly give you more insight into what the impact is of the things that you're doing. You well know that our shelter medicine is an integration of both individual and population health. And you can't have a healthy population without having healthy individuals. And vice versa. If you have an animal that's introduced, an individual animal that's introduced that has parvovirus or pan-Luc and it exposes other animals in the shelter, then you put the population at risk. So it's always kind of an interplay between the two. So let's again do some, I want you to stop and think a little bit. Let's say now that you're in private practice. And who monitors the health of individual pets if you were in private practice on a daily basis? This is not a trick question either. I don't do trick questions. What's the obvious answer? The owner, of course. It's the owner who's observing that animal and sees what it does on a daily basis. And hopefully, if they see something amiss, who is it that they then turn to get information? Hopefully the veterinarian. That's right. They go into the veterinary office where both the veterinarian and the veterinary nurses are attending to what is happening with that animal. So when the animal comes in, there's a physical exam. You're looking for signs of disease. If you find them, in some cases you don't need to do any further tests. In other cases, you need to run some diagnostic tests. You then hopefully come up with a diagnosis, or at least you have a plan. You start developing a plan for how to manage this animal. You then treat that animal. You hopefully say to the owner, either if the animal does well, you don't need to come back. If the animal doesn't improve, we need to see you back. And so you're monitoring the effectiveness of that treatment. And then hopefully, if it is a disease that could recur or could affect other animals in the household, you make recommendations. So you all are very familiar with this kind of thinking. Okay. So now let's step into the shelter. Who monitors the health of shelter populations on a daily basis? Staff, yeah. Now, I mean, sometimes veterinary nurses are walking around each day. They may be helping to monitor. Sometimes the veterinarian may be walking around. But basically, it's the staff that's the first to say, uh-oh, there's something wrong. This animal didn't eat. I see diarrhea. And they're going to then report that to who? They're going to go to the medical staff, right? They may go to the veterinarian directly, but they very often will go to veterinary nurses and say, hey, there's a problem with this animal. We needed to get it on the problem list. Okay. So are there parallels, do you think, between delivering individual and population health? I'm going to suggest to you that there are. And that they look like this, that the physical exam of a population includes, of course, physical exam of individual animals because they make up the population. But at the population level, the question is, what are the diseases you're seeing in this population? How frequently do they occur? Those are the signs of a sick population. If you've got high levels of disease, if lots of cats have a URI or lots of dogs have upper respiratory or kennel cough, upper respiratory tract infections, then that's a sick population, if you will. That's a population that has a problem. You can then further look at those rates and numbers of animals and say, well, which ones are the ones that are being affected? Is this principally affecting kittens? Is this principally affecting dogs that have just come in on a transport? You can begin to break down those in subgroups, the population, in terms of its risk of high levels of disease. Why do you want to do that? Because those are the very animals that you may be at most risk of developing disease if they don't already have it, or if they do, they're the ones you want to target with treatment. Then you're going to have some kind of, and of course you're going to run diagnostic tests, regular diagnostic tests to figure out what the disease is. So again, this is that integration between the population level and the individual animal health. And then you're going to have a plan for changing the protocols, maybe, because you're now seeing high levels of disease in a particular group of animals, or re-examining your current protocols as to whether people are actually adhering to them. And you can then, your treatment plan, of course, how are you going to manage this disease in this population? Is it going to involve improving the biosecurity plan? Does it mean changing perhaps the flow of animals in the shelter, et cetera? And then monitoring the effectiveness. Have the rates dropped? Are the numbers and or rates, and we'll talk about numbers and rates in a few minutes, but have the numbers dropped? Has what you've done to try to address the high levels of disease actually worked? And then hopefully from what you've learned, you make recommendations such that it doesn't happen again, or that you're able to maintain lower levels of disease in your population. So I just want to encourage you to think about your population as an entity that can get sick and that may have low levels of smoldering disease that you could possibly bring even lower than what they are already. Okay. So what's the role of data? You all know the role of data in individual animal. You're collecting data on the signalment in this animal. You are collecting data on the signs, the results of diagnostic tests. Similarly, you want to collect data about how the population's doing. How common are the diseases in this population? What are your most what are your most egregious actors in your shelter? And y'all may have different actors in different shelters, depending on all kinds of circumstances, geographic location, type of animals that are coming in. So you really need to know. It'd be lovely if we could say, oh, all shelters have this, or all shelters have that. It isn't true. Just like no, all individual animals don't have the same risk of disease. So you want to know in your shelter, well, okay, now I want to characterize the signalment in my shelter population. And I want to know what's happening there so that I can then plan to minimize disease occurrence. And I'm saying disease, we could be talking about behavior too. I'm by background more disease inculcated, but you can get rates of behavioral issues at the same time. So what I'm saying about disease often applies also to behavioral issues. Okay, so I believe that data is essential to the optimal population health management. All of you are doing population management already, right? And you may or may not be using data to help you with that. And that's okay. I just think you can optimize. You can optimize the care you deliver to the population by incorporating looking at data along with the other things that you're currently doing. So we're going to talk about each of these things here in the list, where you can use data as a physical exam of the population, changes in disease frequency, indicators of outbreaks, demonstrating the effectiveness of changes to protocols, and then looking at the relationship between the occurrence of disease and outcomes. How does disease affect the likelihood you're going to be euthanized? How does it affect your length of stay, et cetera? Okay. So if we look at the presence and the baseline occurrence of disease, it's kind of like doing a physical exam on the population. So here's a shelter that, these are cats in the shelter, and this is a list of the most common. I guess what we did was we said we're going to look at all of the diseases that had at least 5 cases during the past year. So this is an annual look at their disease rates. And okay, if you look down at the proportion of animals that were affected by each of these diseases, right away you kind of go right up here and say, wow, we have a lot of coccidia in this shelter. Ouch, what's going on here? One of the dangers of just looking at the percentages, though, is that I always encourage you to also remember the denominators. This 22.8%, you don't test every animal for coccidia, right? Usually what you do is you say, I have signs that are consistent with the possibility of coccidiosis, and then I go ahead and test them. So in the case of coccidiosis, this 22.8% is among those that had signs that might have had coccidia that actually did. So that is not a rate of disease in the whole population. That's a rate among those that we happen to test. We don't know. I mean, we could have other animals that are subclinically affected with coccidia. So you can't really use the total population as your at-risk population. Instead, you have to look at it in regards to those that you actually tested. On the other hand, and this pertains to cats, so we'll concentrate on URI. In fact, in this shelter, they had about 16% of their cats developed upper respiratory infections after they entered the shelter. And the question is, are you content with that? Is if 15 of every 100 cats walks through the door will develop upper respiratory? Are you happy with that? Could you lower that? Is there something you could do about that that would reduce that rate and keep those animals from getting sick in the first place? And then you can move on and start making comparisons between dogs and cats. In this particular shelter, and incidentally, this is peculiar to this shelter. It may be true in your shelter, but I don't want you to go away thinking, oh, that's indicative of all shelters. You've got to know what's happening in your own shelter. But here you can say, well, wow, we really have very little problem with upper respiratory. You can see that you've got, a primary problem with respiratory disease in cats here. But compared to dogs, it's very little. They have very little chemical. Mortality, we're seeing more mortality in cats here than we are in dogs. Why is that? In this case, it's probably, well, I know it happened to be our neonates, our young kittens that we were losing. And that's another really good reason to start here. What are the diseases? How common are they? And then you can start going ahead and breaking it down by subgroups and asking the question of why and who's at highest risk. But digress just for a minute. I think most of you know this, but numbers are lovely. They are counts. They tell you how many animals. And you need numbers because you need to know. I mean, you can say 22% of cats are affected with coccidia, but it's not 22% of 1575. It's 22% of those that you tested. So you really need the numbers, how many animals are being affected. That said, you also need rates, because knowing that 30 cats are ill with upper respiratory, without knowing out of how many, it could be 30 out of 40. That's really bad. It could be 30 out of 400, and that's really good. So you need the rate, those animals that are at risk as well. Your rates will require some kind of a denominator and some kind of a designation of time frame. And as counts many times do as well. I mean, you need to know, you don't need denominators, but you do need some kind of time frame. Within which time frame did these cases actually occur? Okay. So you need both. Just a quick reminder, you may have had these back in school, and a lot of people get these terms confused. Incidence of disease is a measure of risk of getting sick. It's, I came in healthy, I didn't have upper respiratory, I didn't have Pan-Luc, and then I developed it while I was in the shelter. And in many ways, this is the most helpful to you, because what you want to do is minimize the likelihood of your animals getting sick in your care. That's on you. Now, obviously, there's some exceptions to that if they come in and they're already incubating. But in essence, most of the disease that we see that develops in the shelter, infectious disease, is on us. We should be trying to minimize the occurrence of that disease. That's different than prevalence, which is a measure of being sick, of having an illness. So when a cat comes in and you test them for feline leukemia, that's a prevalent, at the point of entry, the prevalence of feline leukemia in your incoming population is a measure of prevalence. It is the measure of having disease when they came. You don't know when they developed that disease. That cat could have become positive yesterday, or it could have become positive 3 years ago. You don't know. And it's not that prevalence isn't important, and especially if you're planning for treatment. What's the prevalence of dogs walking through the door that are diabetic? That helps you plan for how much insulin am I going to have on hand? If you are going to treat, how am I going to manage that group of animals with that disease? So very often chronic diseases we look at the prevalence of. But infectious diseases, mostly we're interested in our care. Can we possibly prevent them from getting sick? There are other measures, mortality. You certainly don't want to be, you want to minimize, I mean, you're going to have some mortality. By mortality, I'm talking about animals that die. You don't euthanize them, they die of natural causes. Very often happens in neonatal kittens, right? You lose some of those kittens. Fading kitten disease, we don't really know always why they're dying. So you're going to have some mortality. Euthanasia rate, there we make a choice. We say we're going to end the suffering of this animal and euthanize it. Or it's so aggressive that it is not going to make a good pet, so therefore we're going to euthanize this animal. And then survival, I mean, you can look at it either as, I mean, it depends on how you're going to use it, but survival could be surviving and not having died of a natural cause. But I think most of us in the shelter field, we're looking at survival as 1 minus those that died plus those that were euthanized. What proportion of the animals survived the illnesses that we're looking at. And you can make this very illness specific. What is the survival rate among kittens that develop pan-Luc? What is the survival rate among puppies that get parvovirus, et cetera? Okay. All right. So let's look at some of the things that you might be able to do if you start looking at the population level, and I'm going to use the word statistics. People hate that word. Actually, probably metrics is a better. Statistics means a discipline, but it also means individual metrics or individual measures of disease occurrence or occurrence of something, okay? All right, so let's look at, here's a shelter that back in around 2009-10 really started to pay attention to their average length of stay. And they wanted to get a sense of how are we doing? Well, you can see they've made some dramatic declines in average length of stay. And then you want to continue, even when you have success, you really want to continue to monitor what's happening, because now if you're happy and you feel like you've kind of come to that minimum average length of stay and you're still adhering to your mission, you're not just, you're doing the right things by your animals, providing good behavioral evaluations, you're doing, you're allowing them to be time to be spayed and neutered, et cetera. You want to make sure that this doesn't start to creep up again, right? You want to monitor. This is average length of stay, but when you're monitoring health-related metrics, you're doing disease surveillance. It's like CDC does. They do a lot of surveillance of disease, right? Because they want to know what's happening in that population and when they can start to worry, oh my goodness, we've got a real uptick in measles, for example. And identify and investigate outbreaks. This is an interesting one that came to me some years ago now. A veterinarian called and said, I think I've got an outbreak of infections in my incisions in my cats. He said, we are seeing more of them. I'm absolutely sure of it. And I said, well, how do you know? Have you ever tracked how many infections you see with your incisions? He said, no. But I just have this feeling. And notice that even in 2008, well, these are numbers of infections, but they're not a huge number. This is a big shelter. They probably handle about 10,000 cats a year. So detecting that, he was just on top of it. And I'm sure his veterinary nurses, his staff was also reporting to him, geez, we're seeing more of these. And so the question was, is this really an outbreak, or is it just they're paying better attention this year, right? So we went back, and it took a little effort to do this. This wasn't really easy to do. We went back and we looked at, well, let me go back up for just a minute. These are numbers, right? It could be that we just have more cats coming in this year, right? You might just have more cats. The rate of disease may be exactly the same. The risk of getting these infections may be exactly the same. It's just that they have more cats, and therefore you're seeing more cases. So we had to go in and adjust that for the number of cats that were coming in each year. And these are the actual attack rates or incidence rates in this shelter. And lo and behold, in many cases, it was more than, well, these are months, incidentally. That's January is 1, and the 12 is December. But you can see that clearly in almost every month, we have higher rates of disease. And these were statistics. I ran a test just because I am who I am. I ran a test. But you don't really need to run statistical tests to see that that this is really an increase over what would be usually experienced in this shelter. Interestingly enough, I mean, I just amazed, this veterinarian amazed me, is look at, I mean, 4%. He was very much on top of this, right? I mean, his usual rate ran somewhere around maybe between 0.5 and 1%. So that's not a lot, but he recognized the increase from 1% to 4%. I thought that was, I mean, that's somebody who's really watching what's going on in their shelter. Anyway, so the question then becomes why, right? Why? What caused this? Why did it change? What brought about this increase in disease? Now, we did a lot. I don't have time. Kind of a fascinating story. We did a lot of culturing of cages, and we looked at the antiseptic solutions to make sure that they weren't contaminated, and blah, blah, blah. And everything was coming up negative. We couldn't find any real good reason. And then, much to the chagrin of the nursing staff, the technicians, we said, well, let's take a look at who's doing the prep on these animals and whether or not there are different rates of incision infections among those that were doing the preps. And we looked at it, and you can see the p-value there is greater than 0.05, so it doesn't really look like much was going on there. And then, so we did this, and we were scratching our heads, still not really understanding what might have caused this. And the veterinarian sort of had an epiphany one evening. He called me up and he said, you know, can we break down the techs by whether they were recently hired or not? Because he said, we just hired like a bolus of techs, and usually we hire one at a time, but we hired a group of them, and we trained them as a group, and we were kind of rushed. This was, you know, a busy time of year, and I'm just worried maybe we didn't do as good a job of really getting them into the protocol that we used. So, lo and behold, we looked at recent hires versus experienced techs and found a highly significant difference there. Now, like so many outbreaks, is this absolutely, for sure, 100% the explanation? No. This is a relationship that we found. It's probably the best explanation. By that time, everybody was scrambling already to really, you know, change and monitor and make sure everybody was doing well. But everybody started paying more attention to how they were prepping and all, and the rates went back down to what they had been before. So if you don't know what the usual rate is of something, how do you know if it has really changed? Now, sometimes it hits you right up in the face. If you get a parvovirus, you don't have no parvovirus, and then the parvovirus starts in 1 or 2 puppies, you got an outbreak, period. You got an outbreak. An outbreak is defined as the increase in the occurrence of disease above that which is usually observed. And so if you usually observe 0 cases of parvovirus, if you get 2 puppies with parvovirus, that's an outbreak. I don't care if you only have just 2. It's 2 more than you'd usually have. Okay? So lots of things really hit you upside the face. And a lot of our infectious diseases are like that. But URI, for example, if it goes from 10% to 14%, will you really recognize that? Can you detect that? Obviously, some people can. But the data then reinforce that you have a problem going on in your shelter. Okay. So, all right. What about effectiveness of changes in protocols? And we, as the shelter medicine program, are as guilty as anybody else. We go in, we're called in on a consult, we go in, and we make recommendations. And we walk away and we think, wow, we did a really good job. You know, we really helped that shelter. Did we? I guess we'd love to believe we did. But how do we know? I mean, especially if they call us in on a specific problem. We're really having a problem with upper respiratory disease. Or we're really having a lot more kennel cough this year. We go in, we think we have done a good job. But have we? Have we? And if we have reduced the disease, how much? Has it gone from 30% to 25%? And when we really wanted it to go down to 10%? Can we walk away and pat ourselves on the back? I'm hoping that as we in shelter medicine, encompassing all of us that deliver care to our animals, as we get more sophisticated, continue to develop our protocols and all, that we incorporate as one more tool this looking at our data. Because in many cases, I don't think we really know what the true impact is, the magnitude of the impact of what we're doing. Okay. All right, so what I wanted to say here was, here's a shelter this was the same shelter I was showing you earlier, now on a monthly basis, but in 2010, they decided to really start doing daily rounds and having people assigned to say, all right, this animal, why is it still here? What can we do to enhance its likelihood to continue to move throughout the system? And by 2011, you can see that we had dramatically reduced the average length of stay of animals in the shelter on a monthly basis. Interestingly, at the same time, we started looking at the census. How many animals were actually there on a daily basis, realizing, of course, that more animals usually means more disease, especially if you're overcrowded, if you're beyond capacity. And here we saw, again, a fairly dramatic decrease in the census, or the number of animals that were there on a daily basis. Could you walk around and say, geez, we have less cats in the shelter now? Yeah, you could. But as human beings, our ability to perceive things is not as good as we'd like to believe. And again, we often not only want to know that they're reduced, but we want to know by how much. And then, this was not one of the goals, although we certainly had been learning that if you reduce census and you reduce average length of stay, you will impact disease rates. This happens to be this is a shelter that has had a lot of trouble with upper respiratory tract infections in cats. But look at the drop in rates of upper respiratory tract disease. So it was kind of like a win-win-win. But how would you know? And how much did they drop? And can we now drop these levels even lower? Other questions. I mean, these are certainly not the only questions you could ask. I'm just trying to throw out some examples for you of where monitoring the occurrence of disease in your shelters can help you understand better what's going on and assess what's happening better there. But looking here, this was a shelter that had a fairly high incidence. Well, not terribly high, but a higher incidence in 2013 of upper respiratory, and they were able to drop it in 2014, both in the stray and the owner-guardian surrender group. Incidentally, subsetting your data, once you've looked at the overall population rate, subsetting by age, because age is such a strong predictor of disease, subsetting by source. By source, I mean, are they owner surrendered? Are they transfer in? We often are seeing higher rates of certain diseases in our transfers in, stray, et cetera. Really gives you better insight into what is happening in that population. And can often suggest new questions. If you start using your data, people say to me, how do I know what to ask? I say, well, first of all, what do you want to know? Well, I don't know what I want to know. But if you start looking at your data, suddenly questions pop up. Why is it that we're seeing more disease in older animals coming in? Are we seeing different rates of heartworm from various different areas in the South? I mean, suddenly you start looking at it and questions arise. Now, can you always answer the questions? No, you can't always get an absolute answer, but you know that there's an issue there, and it causes you to think. Too often in shelters, this is not just for medical staff, this is for everybody in shelters. What are we doing? We're running from crisis to crisis, and no time to stop and think. Stop and think, can we change some of this? Taking time out. Having the medical group meet not only to talk about individual cases, but to actually look at some of the population level data together. And this is a team effort, incidentally. This is not just, I mean, maybe one person is working with the data, but you've got to share that data. You've got to let it be known. Everybody needs to know what's happening. All right. So again, by season, we want to look at things by characteristics of animals, by location, if we can, depending on how your shelter is, and by time. So here's a shelter, and they're looking at the number of cases of URI. Does this mean that the risk of upper respiratory tract disease is highest in July and September? What do you think? More animals, exactly. Probably doesn't mean that. We still need to look at the rates to decide that. And lo and behold, look, most people, most veterinarians, if you ask them, when's your highest risk time for upper respiratory, they'll say in the summertime, because that's when the isolation room is full. Well, but you have more animals coming in, okay? I mean, and that's not important. It's just that don't ignore the fact that in this shelter, for example, they had 22% of their cats coming in January and March that were developing upper respiratory. They were kind of slacking off in the winter and fall months because the numbers came down. Everybody went, oh, we got through the heavy season, and they kind of slacked off. And so here's a place where now we can say, hey, wait a minute, we need to use this as a target. We're gonna try to lower the rates here of upper respiratory. All right. This is another one I think that now we're getting where we're bringing euthanasia rates down. These data were collected some years ago. But in this particular shelter, if you were a kitten and developed upper respiratory disease, you were less likely to be adopted, 64% to 42%. You were more likely to be euthanized. And these kinds of data can be taken to your executive director, to your board of directors, and saying, look, if we could get more money, we could hire another veterinary nurse, if we could hire another veterinarian, whatever it is you need. Data helps you make the case. Oh, I think our respiratory rates are too high. Whole lot different than saying, look, 1 out of 3 cats that walks through this shelter has upper respiratory disease. Or we're euthanizing animals. You want to lower or raise our live release rate. We're only at 75, 80%. We're pushing to go to, our goal is to go to 90. But part of that euthanasia is resulting because we've got so many sick animals in the shelter. Take the data with you. You know, I served on the board of directors of Tompkins County Shelter for probably about 8 years myself. And one of the things I learned is that board members who come on often want to know what's happening with the animals. They want to know how often do they get sick? What are their problems? And instead, at least at that time, we weren't telling them much about the health of the animals. We were telling them about how much money we have to raise for we're talking to them about raising money. We're talking to them about personnel issues. And in fact, we didn't have the data. Unfortunately, at that time, we didn't even have the capability of getting the data really easily. But going in and showing them this, they're fascinated, at least in the case where I was, I think they can be fascinated. People get on the boards of directors usually because they like animals, usually because they have an invested interest in the animals. Tell them what's happening in your shelter with the health of your animals. It highlights the medical team, and it also builds that, well, if I need money, this is the reason this is how I'm going to build a case with them to get more funding for the medical program. All right. This is adult cats. Interestingly enough, the euthanasia rate was so high in the adult cats in this particular shelter, it really didn't make any difference whether or not they had the upper respiratory or not. Here's another one where, look what happens in this particular shelter. I'll draw your attention to the senior. Look what happens when senior animals in this shelter get sick. Incidentally, don't do as I did, but do as I say. Have age ranges on here. I don't, what's a senior in your shelter versus a senior in another shelter? I think these were 8 years and older. But what I want to really draw your attention to is look what happens to the senior animals in this shelter once they get sick. It really increases their length of stay. They are suffering, right? So we really want we want to keep them from getting sick. But if you want to argue again for more care for these animals, maybe you need more money, note that this is a problem. And again, you can convince boards of directors, we don't want to have disease here because look what it does. Not only from the point of I'm trying to lower my average length of stay, but that there's suffering going on here. And we don't want animals to suffer. There are all kinds of ideas, guys. These are not the only metrics you could use. You could, if you don't have the capability of calculating rates. Rates are a little bit harder with our software to get at. No question about that. But maybe just looking at, occupancy rates in isolation. That may be a place to start. And incidentally, you don't have to do all of this at one time. If you're not doing it, start with one disease. Start with the most egregious disease. There's nothing that says you have to do this all at one time. You can start small and build it up to doing more. One thing I really would love to, if you're not doing it already, is set goals for your health. Shelters set goals for fundraising. Shelters set goals for capital campaigns. Why shouldn't our medical staff set goals for their animals and health? If you're starting to monitor surveillance and you know what's going on in your shelter and you see problem areas, set a goal to address that particular problem. And so objectives are those kind of broad, I want to keep animals healthy in the shelter. They're these broad statements. Goals are, in fact, very specific. They are time-bounded, and they say, for example, I want to reduce the incidence of canine upper respiratory tract infections by 4% this year. I want to reduce the risk of pan-Luc in kittens by 10% during the kitten season. I want to reduce the unweaned mortality by at least 15% while in foster care over the next year. Very specific. What are your goals? Homework for you. Go home, think about, what are your goals for your medical program in your shelter? What are your goals? Not your objective. You want to keep as many animals healthy as long as you can. I want to provide good medical care. All of those are good. But what are specifically the problem areas that you have, and what's your plan, including what's your goal for addressing that? All right. If you don't set goals, we have a tendency to maintain the status quo. We go on our way accepting what we've always done. We have a tendency to do that. So how might you plan to reduce the incidence of upper respiratory tract infections this summer by 5% in your shelter? What would be your plan? You might want to reduce length of stay, depending on your length of stay. You might want to say, look, we're over capacity. How do we reduce the average daily census? How are we doing with our adherence to biosecurity? What can we do to potentially ensure that what we think is happening is actually happening? And then how do we reduce stress? Those are just some thoughts. You know the tool bag of approaches to managing disease in shelters. Look in that tool bag. Say, what for this particular problem can we do to address it? Okay. Again, if you don't know what happened last year, how do you know that your protocols were effective in reducing it? So you have to continue. This is a disease surveillance issue where you identify what's going on, then figure out what you'd like to change, then change it, and then monitor whether your changes were effective or not. And it's okay to make mistakes, and it's okay. We learn more sometimes by things that don't work than we do that do work. Okay, so don't be afraid. Best medical metrics. You know what? It all really depends on your shelter and what you want to know. I think you really have to have baseline. I mean, I feel strongly about having baseline incidence rates, at least for those diseases that are relatively common. And again, if you want to start with the most egregious, that's okay too. And you can always add diseases as you get accustomed to really looking at that. And then again, I really love looking at data by age, source. I would also add time. I like to look at it by season or monthly, because a lot of diseases, especially infectious disease, vary by season. And then you can begin to look at euthanasia rates by medical conditions. Potentially, you could look at care days devoted to sick cat. You can add to this list. It's really dependent on what the issues are in your shelter. And so how can you do this? You know, you really need a team effort here. And you're going to have buy-in from your veterinarians. The whole team has to really, to me, to be optimally, you're really going to need to say, we need to start incorporating this into our delivery of medical care. And that's a culture shift. That's tough. I'm not here to say this is going to be easy. But I think you really need to get everybody to buy in. And remember, you need quality data. And sometimes, I certainly hear this from the veterinarians. Oh, PetPoint's so hard. I got to put the data in, you know, and it's so difficult. And people cut corners because it's hard to get the data in. And I fully appreciate we as a medical delivery team need to say to the software providers, we need this, and it needs to be easy to get it. And we need to start, I've tried, other people have tried, not that there hasn't been progress, but it really is from the users. You guys are the ones who hold the power to enforce these software providers to make it easy. They made these software programs with very little thought to how you get the data back out. Now, why would people put data in if they couldn't get it back out and use it in some way is beyond me to understand. Okay. The other thing I want to mention here, so get into your reports. How many of you have looked at your reports options in your software? Good. If you haven't, go and start looking at it. Start looking at what is there and what you can do, what kind of information you can get out of there. And if you don't see something you want, ask for it. Ask for it. I love graphing. I think data, many times data graphed is so much easier to interpret than data that's in a table. My eyes glass over when I see data all in a table. Some data you can put in tables. I'm not saying you can't use some tables, but graphing it really brings home what oftentimes is important to see. And you can use Excel or one of the spreadsheets. You don't even need a fancy graphing program to do this. And if you yourself can't do it, get some teenage kid to volunteer. I'm always going to younger people saying, this technology is beyond me, or what's the latest, okay? And then the other thing you want to do is keep a log of events. And this log of events is sort of what's happening in your shelter that helps you interpret data later. So you had a transport come in on the 2nd of July. 10 dogs were brought in from Georgia. Maybe that is what explains or precipitated that distemper outbreak. We forget. Oh, geez, last spring sometime. We can't keep track of it all. So just a brief log of events that could impact the health of the animals in the shelter. The introduction of a transport. The particularly high kitten intake this year, where we were so overwhelmed, and maybe there was a breakdown in protocols because we just were way over capacity this year because of the high number of kittens we got in relation to what we'd had in previous years. So that you can have something to help you interpret the data. And also remember that a lot of times if we go back and look at trends, it may be years later, And if you don't have this log, the new people who may have come in since then don't know what happened. So it doesn't have to be fancy. It doesn't, I mean, I know you guys are, everybody's overworked. You say, oh my goodness, this is just one more thing I have to do. But it doesn't take long to have a log, just to write down, designate somebody whose responsibility it is to fill in this log that could have an impact on the health of animals. So in summary, your data, I think, is a valuable tool to help optimize your ability to care for animals. Go back and ask, what are the questions? What do we really want to know about our health of our animals? What are our most egregious problems? And then certainly start looking at the reports. And if nothing else, start using the data. If you start using the data, suddenly all the little warts in that data start popping up. And then I want to encourage you to keep a log of events. So that's all I have. Thank you.